so I'll put it full screen. So thanks again for the invitation. And okay. Okay, just to this topic will be about the effect of luspatercept in sideroblastic anemia, and especially of the transfusion burden. We know, of course, this is very important for our patients who have low risk MDS, who are often transfused, especially after failure of erythropoietin. And so indeed, luspatercept has shown that it could reduce the transfusion burden in those patients. But I'd like to go into more details of that study, because now we have longer follow-up. So the objective was really here to evaluate the effect of luspatercept on the cumulative number of transfusions. Do you see my slides okay? So the methods was indeed the MEDALIST study that randomized adult patients with MDS with ringed cerebroblast between who were transfusion dependent, red blood cell transfusion dependent, and who received luspatercept or placebo. And what was particularly assessed was the effect of luspatercept during the 24 first weeks. And indeed, in that study, the primary endpoint, which was transfusion independence, was achieved. And that was a superiority. Those are the details here of the MEDALIST study. So those were sideroblastic patients randomized 2-to-1 to luspatercept or placebo. Those results have been published. And indeed, what we try to see now with longer follow-up is the importance of transfusions in those patients. And patients were categorized as low transfusion requirement if they receive less than 6 units every 6 weeks, or at least 6 units over 8 weeks, sorry. And this is quite frequent in cerebroblast anemia, having at least six units every 8 weeks. Often patients are even transfused every 2 weeks. So that's really real life. And so the results are here. So what we can say was that 57% of the patients were considered as low transfusion burden, and 43% as high transfusion burden, and they were well balanced between the luspatercept group and the placebo group. And there was indeed lower transfusion rate in the luspatercept patients. But then when we try to analyze in the next figures the effect on the longer term, and also of the number of transfused units, we can see the difference. And I show the tables. The first here is the cumulative transfusion units during 24 weeks. And as you can see, there is a big difference, which can be seen both in low risk, low transfusion burden and high transfusion burden. And of course, what you should take into account is the responders. The non-responders, of course, are so you see a really important difference between luspatercept responders 2.7 units versus 13 in the placebo arm, and in the high transfusion burden you also see 3.7 versus 24. And of course it's the responders we have to take into account, because in non-responders treatment is stopped at some point, and generally after something like 4 to 6 months. And the cumulative number of visits, so because it meant in many times there are two transfusions in one visit, and you can see there's still a big difference if you take into account the responders, 1.7 versus 7.2 for the low transfusion burden, and 2 versus 12 for the high transfusion burden. And this is the cumulative number of transfusions over time. So overall, there's a big difference for low transfusion burden. For high transfusion burden, the difference is not so obvious, because that takes into account responders and not non-responders. And if you, of course, now analyze responders, you can see a big difference, even in the high transfusion burden. So high transfusion burden patients who respond really largely benefit from the drug. And that was in terms of number, and the same, you can see the same for that's the number of transfusion unit here with longer term follow-up. And at 48 weeks, 144 weeks, which is almost 3 years. And you can see once again a difference between responders, non-responders. And interestingly, patients who are responders really have a very low transfusion burden, 4 units over almost 1 year, 48 weeks. That was in the low transfusion burden above, and in the high transfusion burden, it's nine units for 1 year and 26 for 3 years, which is far less than in the non-responders. So there's a benefit here in those patients. So lower cumulative number of red blood cell transfusion visits over 3 years, and persistent reduction with longer term follow-up. And this is now the cumulative number of red blood cell transfusions, again with more follow-up. Once again, the difference is more marked in the low transfusion burden as compared to the high transfusion burden. But if you analyze once again by response, you can see still a big difference, which is maintained over time. So it's I would say prolonged response, and this is the number of visits. It's about the same. I mean, the number of visits, of course, but which is significant because that's the number of times patients have to come to the hospital. So you can see once again a big difference between responders and non-responders, both for low transfusion burden and high transfusion burden. So the conclusion here is that there is a consistent benefit, first during the 24 weeks of treatment as compared to placebo, and then obviously patients who respond, continue to respond, have a continued benefit. And we know that the median hemoglobin level is related to quality of life, and this is an important component because we are faced here with sideroblastic anemia in whom the rate of progression to acute myeloid leukemia is very low. So the main issue in those patients is really transfusion, is anemia, and the median hemoglobin level is the big issue in those elderly patients who are, I would say, tired all the time, and having a drug that increases the mean hemoglobin level, that reduces the transfusion burden, is beneficial. Now, the drug has been approved. It's starting to be used, and in particular in my country, we're lucky enough to have the drug administered at home, so patients won't even have to go to the hospital for drug administration. And I would tend to say also that probably in the future, we're going to see if the combination of EPO and the luspatercept is not beneficial in those patients, as we showed some years ago that lenalidomide in non-DAR5Q people, when you added EPO, even in case of EPO resistant, was beneficial. So perhaps the next step will be a combination with EPO. And also, of course, we're going to start soon at the French MDS group level, the GFM level, a study comparing luspatercept alone and luspatercept plus EPO in non-sideroblastic anemia who resist to EPO. Because luspatercept was initially selected in sideroblastic anemia because the response rate seemed to be higher in sideroblastic low-risk MDS, but it also works in a substantial proportion of non-sideroblastic MDS, and in those patients, the addition of EPO may be particularly beneficial in terms of transfusion reduction. So that certainly is interesting for the future, and I'd like to thank you for your attention, and I'm ready to take questions.
Okay, thank you, Dr. Fenaux, for this nice presentation. I have two questions from my colleagues. Please comment on the luspatercept effect on survival, although the follow-up is short. And the second part of this question is about the safety. Do you see any progression to high-risk MDS or acute leukemia during the follow-up?
Okay, no, that's very important. Further, the drug is well tolerated. There are very few side effects, and in addition, the sub-Q administration is convenient. Now, in terms of progression, it was shown in the placebo-controlled trial, the MEDALIST trial, that there were no more progressions to AML or high-risk MDS or AML in the treated patients as compared to the control, and almost all patients who progressed had, in addition to SF3B1 mutation, which is the hallmark of cerebral-blastic anemia, had an unfavorable mutation, especially mutation like RUNX1, ASXL1. And in both arms, the few patients who progressed had those mutations. By the way, it's an incentive in those patients to assess those mutations in addition to SF3B1. And now, in terms of effect on survival, it's impossible to determine. Of course, we would need very long-term follow-up, and those are elderly patients who often die from other causes. I think really the aim here is to reduce anemia. Now, is it going to have an impact on survival? Potentially because when you have a better mean hemoglobin level, you have less cardiovascular diseases in those patients. And also you may have less iron overload and therefore less cardiac problems and require less chelating agents. Now, for EPO, for example, it was shown that when you compared EPO-treated patients and transfused patients without EPO, patients who received EPO had a survival benefit. And this was probably not due to EPO itself. It was due to the fact that you maintained a high hemoglobin level. So that's probably the reason in those elderly people that they have less complications. We've tried to assess that in our sideroblastic population and showing that there seem to be indeed less cardiovascular events when you maintain a higher hemoglobin level. So potentially in the future, we may have an effect on the survival, which will be an indirect effect, but an important one, of course. Anemia in the elderly is poorly tolerated. We know that, for example, having 1 gram of hemoglobin less in an elderly person will increase the risk of falls by 50%, and also, hip fractures, etc. So this is something important for our patients.
Okay, the second question is, although the study population is quite homogeneous, approximately half of these patients do not respond. Do you have any biomarker for the response to luspatercept?
It is a bit unclear for the moment. Well, transfusion requirement is one of them. I mean, patients who are heavily transfused, like for any treatment, respond less. But otherwise, it's a bit unclear. But maybe those patients may benefit in the future from the addition of EPO. For example, in a previous trial, we found that lenalidomide in patients without DER5Q had only 25% response rate. When you added EPO, although they were EPO resistant, you increased the response rate to 50%. And this was confirmed by a US trial. So the hope is that in the future, a proportion of those patients who do not respond to luspatercept alone will respond to the combination.
Okay, thank you, Dr. Fenaux, for this nice contribution to our Congress. Have a nice day.
Thank you very much, and sorry for not being able to go to Turkey as well. Travel is difficult nowadays, and yes. Thank you indeed, and have a very nice meeting.
Okay, thank you.